Dr. Luisa Solis-Cohen is a movement disorder neurologist with Colorado Neurodiagnostics in Littleton, Colorado. Her clinical interests include Parkinson's disease, Huntington's disease, tremors, dystonia, and therapeutics, including deep brain stimulation and Botox injections. Dr. Solis-Cohen earned her medical degree from the University at Buffalo School of Medicine and Biomedical Sciences. She completed a neurology residency and a movement disorders fellowship at Beth Israel Deaconess Medical Center in Boston, a Harvard teaching program. She was the recipient of multiple teaching and science awards and has been involved in Parkinson's disease research, particularly the role of DBS in dyskinesia suppression. Dr. Solis-Cohen is dedicated to community outreach and education. I'll turn it over to her now.
Hi, everybody. Thanks for joining today. We're going to be focusing on deep brain stimulation, surgical technique, and therapy. And we like to sort of describe DBS as a team approach. This is a very important part of neurologic management of multiple conditions, and we need multiple players to do that safely and effectively. And so we've got some of the team players here, but of course that is not, those are not all of them. Myself, Dr. Zaza and Dr. VanSickle have kindly agreed to help describe this therapy and some different aspects related to it. Next slide. So again, this part of neurology is very team-based. It's a neurosurgical and neurological approach to symptom management. Thinking about DBS really is a long game approach where a lot of thinking comes in beforehand as we're considering if a person is a good candidate for surgery or not. We're talking about an evaluation with a neurologist who typically has movement disorder expertise. We're examining folks off and on medications if that's appropriate relative to their diagnosis. We're involving our neurosurgical colleagues for their expertise about where the target should be placed, certain technical aspects, and whether or not they're a good candidate overall. An MRI brain is often a good step in this approach, and a neuropsychologist to evaluate pre-morbid or what their baseline mental status is. The DBS surgery, I'm going to turn that over to Dr. VanSickle later on to talk about those components, but there's 2 steps involved there. And then back to the neurology world for initial programming and multiple subsequent steps of programming. And I'm going to, I think, turn it over to Dr. Zaza. Oh no, I'm turning it over to Dr. VanSickle. I'm sorry. Just want to make sure I'm doing this correctly. Let's see, I'll wait for them to pull up the appropriate slides. It looks like Dr. VanSickle is going to go first. Perfect. Let me introduce you, Dr. VanSickle. Of course, he needs no introduction. He's a board certified neurosurgeon who works with Neurosurgery 1 in Littleton, medical director of Denver DBS Center. Dr. VanSickle earned his medical degree at the University of Pittsburgh School of Medicine and completed his residency at the University of Colorado Health Sciences Center. Before pursuing medicine, he earned his PhD in biomedical engineering at the University of Pittsburgh. So his engineering background allows him to have this special draw to movement disorders and specifically to deep brain stimulation. Recognizing the reluctance of patients to undergo DBS while awake, he's helped pioneer the asleep DBS procedure and went on to become the first neurosurgeon in the nation to perform this procedure with the use of robotic guidance. Dr. VanSickle now teaches his technique to neurosurgeons throughout. Welcome, Dr. VanSickle.
Thank you. Thank you so much for the introduction. I think we're change the order just a little bit. Dr. Zaza is not on. Hopefully he'll be able to join us here in a little bit. So we're going to talk a little bit about deep brain stimulation, what it is and why it might be useful. And then how we do it at Littleton Hospital and how it's maybe a little bit different than done around the country, though The technique appears to have spread around the country, so most people seem to be offering some form of this now nationwide. No, that wasn't always the case. Here we go. Hopefully this slide will, oh, nope. This is actually a before and after little video. Maybe the person controlling the slides can click on those and get those to play. If not, that's okay. There we go. And then just click that play button there. Play button there. I guess they won't allow you to play them. In any case, these are before and after demonstrations of deep brain stimulation. This is actually my very first patient that I ever operated on. This surgery was done almost 16 years ago. We did it with an older technique. What you would see if the videos were running would be that in the upper left-hand corner, this gentleman can barely tap his fingers together. He shuffles when he walks. He has what's called festination. So when he gets up out of a chair, he gets stuck where he can't get going again. Some people call that freezing of his gait. Very rigid, lots of tremor, one arm worse than the other. But the little vignette on the right shows him walking up and down the hall with a smile on his face, good arm swing, no tremor, taking big strides, not freezing. It was this gentleman that really convinced me to try to improve deep brain stimulation. This first case we ever did, nowadays we can do a surgery in about an hour and a half. But at this time, it took us about 7 hours to do a surgery. That's because we're using one of the older awake surgery techniques. Back then, the complication rates were quite a bit higher than they are today. So what I realized was when everything went well with these surgeries, people did really, really well. So my goal was to try to re-engineer the surgery to allow these good quality results for virtually everyone. So what is deep brain stimulation? So deep brain stimulation is a pacemaker for the brain. As you can see, this gentleman here on the left side of your screen has 2 devices in the chest. Each of those look like a overgrown pacemaker, and you can see the wires coming up the neck behind the ears and going into the brain through connectors that are behind each ear on each side. The leads go deep into the brain, hence the name, deep brain stimulation. On the right, you can see some of the control software. This happens to be the Abbott device. The iPad is how a clinician would program it. And the little iPod Touch or cell phone is how you can control it yourself. So your clinician, that is your movement disorder neurologist, would set up the programming in the device, and then you would have some parameters you might be able to change yourself. With Abbott, they either give you a device that you can carry with you as a separate device. It's actually made by Apple. So if you peel back the Abbott cover, it says Apple on it. Or if you prefer, you can actually have the software put on your own iPhone, so you don't have to carry a separate device, and it can interface with your pacemaker for the brain, if it were. This shows 2 of the different pacemakers here on the right side. There's Infinity 5 and Infinity 7. Infinity 7 is the bigger one. I tend in my practice to use 2 small Infinity 5s. That puts less stress on the incisions, a little less complication rate, and the battery life is a little bit longer. Though some people who might be avid shooters will want to have one generator on one side that controls both electrodes, and we do that technique as well. The electrodes are shown down below. They're kind of hard to see. There's those 2 horizontal lines that are below the iPad and the cell phone there, and those are the electrodes that go in the brain. They're very hard to see because they are very small. Now there's a couple different targets that go into the brain. One of the targets is for the subthalamic nucleus and the other one's for the GPI. And these are both the targets that we would use for Parkinson's disease. Another target called the VIM, and forgive me if I don't pronounce it because the initials are for 3 words in Latin or Greek, is part of the thalamus. The STN and the GPI are the locations that we typically use for Parkinson's. Some programs will only place leads in the STN for Parkinson's. Some other programs will only place the leads in the GPI. And in our program, we can use either, depending on what your circumstances are. Sometimes some of our older patients with more difficulty walking, the GPI might be a better choice. Some of our patients with higher medication utilization, maybe a little bit younger, might actually choose the STN. That might be a better choice for them. And we'll work with you to pick out what would be the best option for you. And that's one of these team issues where myself as a surgeon working in conjunction with movement disorder neurologists can help pick out what the right target should be. For essential tremor, the target is almost always the VIM. And that target can sometimes be used with Parkinson's disease, though rarely. It is typically used when you only want to control tremor because it can't really control the other symptoms of Parkinson's. But it's an excellent location to use if you have essential tremor because it's probably the best at controlling tremor and doesn't have many or really any side effects from that location. So we'll go back to that for one more second. The key thing, and especially true if you look at the STN, which is that right brain. So imagine this is looking at your brain face on, the yellow part there being the subthalamic nucleus. And the important key thing to note about that is that it is very, very small. Being very small, the trick of the whole operation really is to get that electrode, which is shown actual size there in that little call out window relative to the size of the STN. The trick of that is to get that electrode into exactly the right location. Sometimes deviating by as much as a millimeter or so means that it won't work well. So how does it work? Well, for Parkinson's disease, dopamine is an inhibitory neurotransmitter. It is a neurotransmitter which slows down the firing of other neurons. Unfortunately, with a deficiency of dopamine, because those neurons are unfortunately dying off, neurons begin to overact, and that overacting can create symptoms such as tremor, rigidity, slowness. It's really an overacting of neurons that creates that problem. The electrical stimulation replaces that inhibition in a very targeted way in just the area that needs it. Therefore, the electrical stimulation is, think of it as electrical dopamine. So does DBS work? Well, it turns out there's more evidence behind deep brain stimulation than there is behind almost anything that we do in medicine. Here's just a few of the trials. Some of these are just a little bit older because this has been well put to bed now. And notice where these publications are. So two of them here we show are in the New England Journal of Medicine. One is in the Journal of the American Medical Association. And one of these is in Lancet. Actually, three of them are in the New England Journal of Medicine. These are the three most prestigious publications in all of medicine. And notice what the titles show is every one of these is a randomized controlled trial. So that is the best quality of evidence we can have in medicine, where you take one group of individuals and they get to have a therapy. The other group doesn't get to have it, at least not right away. And then we compare those groups with each other after the fact. And the comparison is done in a way where the person doing the comparison, usually a doctor, doesn't know whether they had the treatment or not. That's called a blinded randomized controlled trial. There are more blinded randomized controlled trials demonstrating that deep brain stimulation works than there are for things like having your appendix out if you had appendicitis. Now, it doesn't mean I don't want you to have your appendix out if you have appendicitis, because if you don't, you might die. But the DBS has been proven over and over and over again with high quality research published in high quality journals that indeed it does work, with the outcomes generally being that it improves your quality of life. Here's one last little paper that I sometimes show, and this is not as good evidence as those other papers. So just to be clear, this is a retrospective study. This was done in England in the NIH, the National Health Service there, NHS, where they offered DBS to a large number of people in 2001. In 2011, they wondered how they were doing, and it turned out that if you chose to have DBS, keep in mind not randomized, because some people chose to get it, some people chose not to. And it wasn't prospective looking forward, it was looking backwards. But those people who chose it had a less likely chance of dying from respiratory complications or cardiovascular complications. And in fact, what you have on the left here is a life curve where 100% of the people are alive at day one. And those people who didn't choose to get it are the ones in the green lines, and the people who chose to get the DBS are in the blue lines. And 1 equals 100%. So individuals tended to live longer if they had DBS versus if they didn't. That is not because their Parkinson's was cured. It was just that it was well treated, leading to more mobility, and more mobility and getting around easier meant the heart and the lungs did better. And so it just shows again that DBS is a good treatment for the symptoms. It doesn't cure them, but is a good treatment for the symptoms. But that can lead to other positive health benefits. So who is a candidate for DBS? So just to make it really simple from a Parkinson's perspective, this is from the FDA, 4 years after your first symptoms and 4 months or so after your motor symptoms are no longer adequately treated, you might, and I want to put might be a good candidate for deep brain stimulation. And so the key things to remember there are 4 years and 4 months. And working with your neurologist or your movement disorder neurologist, you should be able to assess that issue. Keep in mind, this should be before significant balance problems develop and before significant cognitive problems develop. And the reason for that is because deep brain stimulation doesn't really treat balance problems. It can help with the freezing a little bit, or even quite a bit in some individuals, but freezing is very difficult to treat. And it clearly does not treat cognitive issues. So if you wait after the 4 years and 4 months, 5, 6, 7, 8 years, maybe 9 or 10 years, and then develop severe balance issues, severe cognitive issues, you've really aged past the point in time where deep brain stimulation can be of benefit. And all of the quality of life benefits that deep brain stimulation could deliver are lost to you. So I've heard many individuals come to me and they say, my doctor told me that I wasn't at the end of the window for having DBS. And the window refers to that time frame in between these two things where deep brain stimulation is allowed. And my always thought to this is you really don't want to do deep brain stimulation at the end of the window. You want to do it at the beginning of the window so you can have better quality of life and enjoy the benefits of it over that period of time. For some individuals, that window is quite long. For some individuals, that window can be short. Now, for essential tremor is really quite a bit easier to assess. Essential tremor is a single, in most cases, is a single symptom disease. Some individuals can have some balance issues associated with it as well, with some variations of essential tremor. But you should have severe disabling essential tremor. If your tremor is not disabling or severe, then having surgery for it doesn't make a ton of sense if they just have a mild small tremor. Unlike Parkinson's, where we should always do both sides, essential tremor is not that way. If the tremor is really bad in one side, but not bad in the other side, we could just do the one side and treat tremor, say, in a right-handed individual where the left hand was otherwise okay. And the other indication is simply absence of a medical contraindication. In other words, some people simply are not healthy enough to have surgery, but most people in the essential tremor category would be. So if you have a severe disabling essential tremor, and those are kind of things that are typified by having difficulty putting on makeup, having difficulty writing, having difficulty taking a drink with one hand, having difficulty using utensils. If that bothers you, then we'd want you to see either myself or one of our movement disorder neurologists, because we can probably help you alleviate that tremor. So let's go into some of the things. Now, all that so far is ways you could be treated and indications for every program in the entire country. So nobody would really be any different anywhere else. This is an area where maybe we're a little bit unique by offering a sleep robotic DBS. And what we know in North America, at least, is that our program was the first to do a sleep robotic case. And we think it might be actually in the world, though we don't know that for sure. So here's how deep brain stimulation used to be done. It used to be done as an awake surgery, and you can see this gentleman is awake, And you can see that there's this big plastic wrap up there, and that plastic wrap is to keep a sterile field on the back side of him, and then he's not sterile on the front side of him. And you can see this lady is testing his ability to do movements, and during the process of the surgery, those tests would be ongoing to make sure they got in just the right area. Electrodes are passed down through the brain repeatedly, and these are this, if you see, there's 2 electrodes here. There's a fatter one with 4 contacts on it, and there's a narrower one just below it that is 1/4 of a millimeter thick, and that's the small one. That's the fine wire microelectrode that's passed down through the brain multiple times to try to find just the right spot. These are some cell firing types that you might see. So this is a cell firing of a subthalamic nuclear cell. That's the first pattern that you see. And the second one you see is in the anterior thalamus, and that is close to the VIM. And in fact, you can actually see a little burst of energy in there, and that's actually tremor that's happening in that individual. So you can actually see that that's a tremor cell. And this is how we used to always do these surgeries. We would pass these fine wire microelectrodes multiple times down through the brain, making multiple stabs through the brain until we found just the right area. Then we put the big electrode into place, test the big electrode, and then lock it into position, and then move on to the other side. And then for the longest time, this was felt to be the gold standard. But there were a lot of things that told us over time that maybe this really isn't the gold standard, because not everybody did perfectly. And it would be silly to expect that everybody would do perfectly with every surgery every time. But there was actually quite a few individuals who were doing unacceptably poorly. So here's potentially why that's the case. I see Dr. Zaza has joined us, and we'll have him talk here at the end. So when we did these things, these surgeries, a large number of different holders were developed in order to place these electrodes. In the upper left is the most common. That's a Lexel head frame. It weighs about 8 pounds. Pins go in the head, and it has a big arc and ring over the top, and you actually put down an electrode into the brain. Based on imaging, this is marked off like a ruler, just like a ruler in your desk drawer, and that's how we measure just the right location. Other ways, on the upper right, you can use a camera system, and you can see up there that there's little silvery balls, and it's on a gimbal system, and then those silvery balls tell you if you're lined up by a camera across the room that sees where they are. In the lower right is a pre-printed platform made by the Fred Hare Corporation. The way that works is that you put little screws in the head a week before the surgery, that you design this platform and have it manufactured, it's sterilized, and then used at the time of surgery. In the lower left, you see one made by a company called ClearPoint. This is designed to do sleep cases in an MRI setting. And in the middle, you see a robot, and there are several robots on the market. This one happens to be a robot made by Mazor. And we always think that a robot should have like little arms and legs, like the Will Robinson robot from Lost in Space, but a robot really is any kind of device with an electrically adjustable position. So one could think of it really as an electrical adjustable jig or guide. Robot sounds cooler though. So why were we getting, with these awake surgeries, why were we having these inconsistent results? And here's one really good insight that came to us from a study which was done by a gal named Beth Holloway. And what she did is she put in, instead of 1 microelectrode, she put in 2 microelectrodes, and she put them at the same time, and then got a type of a CAT scan during the operation. These electrodes were put in volunteers, and so they were having surgery anyway, but they volunteered for this special surgery, and they were put in 2 millimeters apart at the very top of the skull. At the very tip of the electrodes, the distance was measured based on the CAT scan, and if they were put in 2 millimeters apart at the top, they should be 2 millimeters apart at the bottom. It turns out they weren't. It turns out that actually these tiny electrodes bend quite a bit, and that bending creates quite a bit of error. And using her paper, I can show what a sample grid would look like. If you were trying to do electrodes into the subthalamic nucleus, and imagine this oblong sort of almond-shaped diagram here on the right is a subthalamic nucleus, and you're trying to do electrical passes with these electrodes into that subthalamic nucleus, each color representing a different pass. You think that you're getting a pattern looking like this nice even grid shown on the first figure, but on the second figure is what you're actually getting, because each of these electrodes bends by a random amount, and they actually bend quite a bit. So it scrambles the information that you think you're getting, and that creates quite a bit of error or deviation with an awake case. Another example of this is these electrodes that were put in a study done out of Paris. What they did here is they got a CT and an MRI, and they identify, again, you see that almond-shaped target there in the upper left panel. The green and pink and brown colors are different areas of that subthalamic nucleus. And each of the little dots here on the other panels demonstrates one of the contacts on the leads. And what they did is they did over 300 patient operations awake, and they went back with their imaging and said, how good of a job did we do? And they looked for where those electrodes were relative to the actual subthalamic nucleus. What they found was that they didn't do particularly well. And it has scrambled my slide there a little bit. It turns out that they only hit the target about 2/3 of the time, with about 1/3 of the time missing, and a small percentage of time missing the subthalamic nucleus entirely. These diagrams are diagrams of UPDRS scales, and these lower is better. The black is their baseline, and the green and pink are the different areas of the subthalamic nucleus. But the blue is an area adjacent to the subthalamic nucleus called the zona incerta. And about 1/3 of the time, they actually hit the zona incerta rather than hitting the subthalamic nucleus. But doing an awake surgery, they noticed an improvement. So if you notice, it's better than their baseline because it's a lower score, but it isn't as good as they could have done had they hit the right area in the first place. And that's sort of the problem with the awake surgery, is you can get fooled or tricked with nearby areas that do give you some treatment effect, but not as good as maybe you should have gotten. So next slide. So in comes the robot. So here is a picture of that same nut-shaped or almond-shaped subthalamic nucleus, but this is on a real person's MRI. You can see it there in black. It's on the left side of the brain, and the crosshairs have it lined right up. And you can see other directions or other planes where we're going on those two panels in the upper right and upper middle. And we're going to try to hit that exactly, but without the person having to go through an awake surgery. And we're trying to avoid the complications or problems of multiple penetrations in the brain. So we do it using a CAT scan. This is a live CAT scan we have in the operating room. This is a serotomes. Subsequently, we have a new version of this called the omnitome, and we were the first ones in the world to have that in the operating room setting as well. And you can actually see, I'll go back one slide there. You can actually see the robot on this individual's head. By the way, I don't shave the hair. This gentleman just happens to be bald. What we've done here on this left panel, where you can see a picture of the brain, is we've gotten that CAT scan and we've adjusted the contrast. So all you can see on the CT scan is just the cannula itself. And that's represented by a white dot. And the span of it across it's measured by that 1.8 millimeter sign. The oblong almond area is still visible because that's the MRI. So what we've done is we've overlaid that MRI on top of the CT scan, so we can now see the electrode or the cannula in concert with the MRI findings, and we can now tell that this person's cannula is indeed placed in the right location for sure before they ever wake up. And yet we didn't have to do any testing with them being asleep. In fact, we actually published it. So we actually looked at the actual electrode placement relative to our planned trajectory with the first 241 electrodes. And we determined that we deviate on average less than half of the width of the electrode itself. but that's not good enough. So even though we can now place an electrode less than half the width of the electrode itself away from our intended target, there's ways we can make it even better. And that's through directional stimulation. Abbott was the first to introduce this. Now all the manufacturers have it. So Boston Scientific has it, as well as Medtronic. And here's what it is. So it's easiest to see on this left diagram. Normally, before, we had 4 contacts on each electrode. We had 1 contact at the bottom, 2 in the middle, and 1 on the top. Now instead, we have 1 on the bottom. We have 3 on each, where each one was before, in the middle, so for a total of 6 in the middle, and then 1 on the top. Those middle ones allow us to turn on or off selectively each one of the sides, thereby steering the electrical current forward, backwards, left, right, as well as before, up and down. By being able to steer this current, we can't move the stimulation a lot, but we can move it roughly 0.5 millimeter or so. And that allows us to virtually move the electrode. That is, not physically, but we can move it as if we were moving it, even after it's been placed. So if we can put in an electrode within the half the width of the electrode, and then move it half again later after the fact with virtual movements, this allows us to have complication rates that are much lower and outcome rates that are much better than we could have, and much better, not much better, much more consistent than we could have before. Steerable current allows us to increase the therapeutic window. So what the therapeutic window is every drug, every device, everything in medicine has a point at which time is subtherapeutic. That is, it doesn't really work yet. You don't have enough to have any work. Imagine taking an Advil and you only took 1/10 of one Advil. It probably wouldn't do anything for you. And every drug or every treatment has a point at which, if you take enough of it, you're going to have a side effect and make you potentially sick. Our drugs that have a big therapeutic window are oftentimes sold over the counter because it's kind of hard to overdose on them. And oftentimes the treatment effect is fairly predictable. Our drugs that have a really narrow therapeutic window, like our narcotics, which are addicting and have all kinds of side effects and have to be managed, they're the ones that require prescriptions. The same thing's true actually with deep brain stimulation. The good thing is that by using steerable current, that therapeutic window gets bigger. That means that it is easier to program and easier to get where you can have a good treatment effect, but not yet have a side effect. It turns out that by using directional stimulation, that there is about a 35% increase in that therapeutic window. And that also means that as you age and as Parkinson's or essential tremor gets worse, we can actually turn it up more in the future than we would have been able to had we not had such a wide therapeutic window. It also means we need less stimulation. And by using less stimulation means your battery will last longer. That's a huge benefit because nobody wants to have to go back to surgery to have their battery changed. That's one of the major reasons I like to use 2 small batteries rather than 1 big one, is it simply lasts longer and you need less surgeries overall. Make sure we're on the right slide here. There we go. It turns out, actually, and I don't think anybody was predicting this, but about 85% of individuals will actually be best programmed by turning on just one segment on one side. And the good thing about that is that tends to be very efficient and give you long battery life. It turns out that about 3 out of 4 clinicians prefer to program using steerable current. It turns out that the patients, when programmed using steerable current, about 2 out of every 3 prefer to have the programming in that manner. They feel like they're doing better. So let's look at the measurables of some of these new techniques. So I think this is really key. And then we're going to turn it over to Dr. Zaza, who can give us maybe a little bit better idea of the indications for DBS for Parkinson's, as well as the indications for essential tremor. So one of them is shorter surgery time. So this is a paper that was published in 2013, and it was a survey of a large number of different surgeons and a large number of different techniques. And each vertical bar on here represents a different technique for doing surgery. And on here is shown that our technique time, and notice that it is the fastest. So we were actually able to operate much quicker using less operating room time, less time under anesthesia, and less time where you're exposed to potentially getting an infection. And that's actually been shown to reduce our infection rates. The awake surgeries simply take a lot longer in order to be done. And so all the other different techniques, all in general, take longer. And this has been borne out in our infection rate. So keep in mind, this is our first 241 leads we placed. And we're looking for something good to compare it to. Oslo University, which is an excellent location for getting deep brain stimulation. And they do surgery awake. And they published a nice study of 550 leads. And their infection rate was roughly 3.5% per lead. During this study, our infection rate was about 0.3% per lead, or 10 times better. And it's not that we're 10 times better surgeons, it's simply we had a shorter surgery using better technology, leading to a much lower infection rate. So remote care. This is something that's actually very important here in the state of Colorado. Because Colorado is overall a rural state. Many people on this call might be listening in from the city of Denver, where getting to a doctor's office might not be so bad. But on the other hand, people might be on this call from Durango or from Kansas or Nebraska or Wyoming or Montana or Idaho, or even out of state on the East Coast. We've had many people fly here in order to have the benefits of the sleep robotic care. So this is a picture of what is coming. This is coming our way. We all know it too well. It can be difficult to get here. It can be difficult to get to see a clinician. And so this is what a remote care session looks like. So on the back is that clinician programmer like we showed, and on the front here is your own phone, or it might be the device given to you by Abbott as part of the surgery. And you can see your clinician, they can see you, and on their device, linked through your phone, they can actually see the settings of your stimulator, and they can make adjustments in programming settings to your stimulator. So this is like having a Zoom visit with your doctor, but more so. It's like a Zoom visit on steroids, where they're able to actually make programming adjustments to your device. It's probably not the best way to go for the initial programming, which can be quite complicated, especially in the case of Parkinson's disease. So the initial first few visits, you should expect to go see your clinician. But as your device matures and your programming matures, when you're checking in with your doctor and want to make a few tweaks or a few changes, or maybe you have to make a sudden change because things are, maybe you went forwards and you on second thought should go back to the old settings. This is something that can be done remotely, saving you significant travel time and effort to get in to see your doctor. That's the little video showing it. I actually, in a lot of my talks showing, this is actually one of my favorite patients. He has severe Parkinson's disease. He has bilateral deep brain stimulation in. This is him rock climbing with a bilateral deep brain stimulator in place. He's actually one of the childhood friends of another neurosurgeon, my partner, Dr. Adair Prawl. And he knew that I was doing this surgery, so I did his surgery for him, and it's kept him active and kept him going. So at this point, I think we'll turn it over to Dr. Solis-Cohen to introduce Dr. Zaza.
All right. So Dr. Zaza looks ready here. Let's give him an introduction. So Dr. Zaza is a fellowship-trained movement disorder neurologist with CHPG Neuroscience and Spine in Lakewood, Colorado. His experience and special interests lie in movement disorders and neurodegenerative diseases such as Parkinson's, atypical Parkinsonisms, essential tremor, dystonia. He is passionate about holistic, patient-centered care. Dr. Zaza received his bachelor's degree in biology at Texas A&M University, earned his medical degree from University of Texas Medical Branch at Galveston. His postgraduate education included a neurology residency at the University of Texas and Austin Dell Medical School, where he served as chief resident, and followed by a movement disorders fellowship at the University of Texas Health and Sciences Center at Houston McGovern Medical School. Welcome, Dr. Zaza.
Thank you so much, Dr. Solis-Cohen and Dr. VanSickle, for the beautiful introduction. I apologize for being a little bit tardy. My clinic ran over, but thankfully Dr. VanSickle was able to jump in. So we'll do things a little bit backwards today, but that's okay. So today I just want to talk a little bit about, first, history of surgical treatments of Parkinson's and essential tremor, and then a little bit about the indications of DBS for Parkinson's and essential tremor. Now, of course, essential tremor and Parkinson's are two of the most common indications for deep brain stimulation. In Parkinson's, motor fluctuations and dyskinesias affect almost half of patients with Parkinson's after 5 years of levodopa therapy. These can interfere with quality of life, and while medications do a great job to some extent, a lot of times they aren't able to be controlled with just the medicines. DBS has been shown in Parkinson's to improve quality of life, motor symptom severity, and then also reduce those drug-related motor complications. And in fact, DBS combined with medications has been shown to be superior to controlling those drug-responsive motor symptoms compared to just medicine alone. Now, in essential tremor, unfortunately, we are kind of limited on the therapies that we have as far as medicines. And so those medicines that we have can only be effective in only half of the patients with essential tremor. And even in those that do well with the medicines as far as controlling the tremor, they experience side effects. And so DBS is a great second-line treatment for medically refractory patients with essential tremor. And it can improve the tremor by over 60%. When you're talking about history, as the same, the surgical treatments of Parkinson's and essential tremor, this was able to form the principles to talk to the end of the advanced techniques like he's using these illustrate. So slowly deep brain stimulation is just the result of whether it's the treating half of surgical techniques. It's generally the top of the picture is Victor Horsley. In 1990, when he tried to treat 15-year-old boy with severe.
Dr. Zaza,
It's
can I interrupt you? Your microphone has gone out. So we're having it's kind of warbly. We're having a hard time hearing you.
how was that?
Much better. Thank you so much.
Okay. So I was just saying that Mr. Victor Horsley wanted to, in 1909, treat a patient with severe involuntary movements. And based on some early work done in the late 1800s on the brain circuitry, he created a lesion in the primary motor area. Now, this resulted in the abnormal movements getting better, but the patient was unfortunately paralyzed after that. Hoping to maybe improve the involuntary movements such as tremor without causing this paralysis, he partnered up with another gentleman who's at the bottom right, Robert Henley Clark, to start maybe targeting areas outside of the primary motor cortex. And so these two developed the first skull-mounted stereotactic frame. This used external landmarks on the top of the head to basically guide a probe down into the brain and target a structure deep within this monkey's brain. Okay, so this was not done first in humans, it was done in monkeys. Once they got to the target and deep in the brain, they would apply an electrical current to the tip of the probe, which would create a small lesion in the brain. The advantage being that it's very small and doesn't spread to other structures and would hopefully cause less problems. This was only used in animals up until 1947, when this German gentleman, Ernest Spiegel, applied that frame to humans. This allowed him to, instead of doing a big open surgery, to make a small hole in the skull through which he could introduce the probe. Because of the success of this surgery, this ignited a very wide range of different types of targets and also different ablation techniques over the next few years. And in 1950, the technique was so successful that it decreased mortality from 10 to 15% with the older procedures to just under 1%. This went on until this gentleman up here at the upper right, Dr. Irving Cooper, when he was performing a surgery, actually injured an artery. And then post-operatively noticed that this patient who had Parkinson's now had improvement in many of their Parkinson's symptoms. Because he knew that where this artery supplied in the brain, a structure called the basal ganglia, he thought that maybe creating lesions on purpose in that structure would help. And so that's where we get the procedure called pallidotomies. After that, there was some further research by groups in France and Germany that realized, well, while the basal ganglia is involved, actually downstream of the basal ganglia, there's a structure called the thalamus that helps to coordinate a lot of the signals coming from the cortex and going out to the rest of the body and vice versa. And then they were even able to look at a smaller substructure within the thalamus that specifically had to do with tremor. And they realized that if they put a lesion in that structure called the VIM, then tremor in both essential tremor patients and Parkinson's patients would get better. This caused a flurry of lesioning type procedures over the 1960s, up until levodopa was introduced in 1969. And so after levodopa was introduced, now we had a more useful medical therapy for Parkinson's. And so the surgical therapies didn't receive as much attention after that. You know, patients with really bad essential tremor and other types of tremor may still have surgeries, but it had kind of moved at that point to medical treatment for Parkinson's. Now this slide is a little bit of a detour because over the next few years, there were some neurosurgeons, one in the USSR actually, and another in Western Europe, who were using chronic electrical stimulation intraoperatively to help patients with tremor. Now, they, at that time, didn't have the technology to miniaturize the pulse generators so that everything could be implanted, but they did demonstrate that by applying this electrical stimulation to certain areas of the brain, the same areas that they were doing these lesioning procedures on, namely the thalamus and the basal ganglia, that patients would have improvement. Now, again, since they weren't able to miniaturize the technology yet, it was really only used to help target intraoperatively where the lesion should be placed. But it still acted as a proof of concept that these things would maybe be a potential treatment. Now, you know, over the 80s and 90s, as I said, patients with Parkinson's disease were being treated with levodopa now, and everything was working very well at first. But eventually, the movement disorder community started to run into issues with chronic levodopa therapy, namely dyskinesias, motor fluctuations, wearing off phenomenon, that sort of thing. And so that kind of reignited a little bit of interest into surgical therapies for Parkinson's disease. And so these two French gentlemen, Alim Louis Benabib and Pierre Pollock, first reported success in 87 by applying deep brain stimulation to patients who had been treated on the other side with the thalamotomy. Now, you know, since the late 70s, they had the ability to create smaller implantable electrodes. And so they were able to show that not only does the lesioning procedures help, but you can also use chronic deep brain stimulation to accomplish the same goal. They went on and actually did this in a bilateral VIM DBS the next year. And that showed that both Parkinson's and essential tremor patients would have improvement in their tremors. This began to led to VIM DBS replacing thalamotomies for essential tremor treatment. And then in 1997, the FDA approved DBS for both Parkinson's tremor and essential tremor. Now, as I said, in the 90s, we were starting to encounter the problems with chronic levodopa therapy. And while VIM DBS did help tremor in Parkinson's patients, it didn't help the other symptoms of Parkinson's, namely the rigidity and the bradykinesia. And so in the 90s, the pallidotomy procedure, the lesioning procedure of the basal ganglia, was revived and largely overshadowed DBS in clinical practice in the 1990s. But research continued, and Benabib and Pollock in 1993 tested a new target for deep brain stimulation, the subthalamic nucleus, which not only had improvement in tremor, but also showed improvement in rigidity and bradykinesia. And then the following year, another neurosurgeon, Jean Siegfried, did the same thing, but in the basal ganglia, in the area where the pallidotomies were being done. And so because of these studies, more and more studies multiplied until the FDA actually approved DBS of the GPI in the basal ganglia and the subthalamic nucleus for Parkinson's disease in 2002. So that kind of starts to segue us into the actual indications for DBS in Parkinson's and essential tremor. Now, when DBS was first approved for Parkinson's, it was thought that really only patients that had completely exhausted all medical therapies and had severe end-stage Parkinson's would qualify for DBS. This has changed over the last 20 years or so, and specifically changed after this study called Early STIM in 2013. Now, Early STIM was conducted in France and Germany, and it essentially established that implanting and utilizing DBS early in the course of Parkinson's disease is actually associated with improved quality of life. So it basically compared Parkinson's patients that were on best medical therapy to those that had bilateral STN DBS. But specifically, they were looking at younger, earlier stage patients. So these patients were all under 60. They had had Parkinson's for at least 4 years, whereas before the recommendations were you had to have Parkinson's for at least 5 years before you could consider DBS. These patients also had motor fluctuations and dyskinesias for less than 4 years, and when they were in the on medication state, meaning they were on their carbidopa levodopa, they had mild Parkinson's symptoms. So after 2 years, it was clear that quality of life, motor control, emotion, cognition, and communication were all superior in the DBS group compared to the medicine group. Further studies also demonstrated that earlier DBS was also associated with less operative risk, both perioperative complications, less complicated post-operative course, and then more effective rehab after the operation. And so based on the results of Early STIM, the FDA actually revised its approval of DBS in Parkinson's disease to patients in early stage Parkinson's. So the things we look for as far as indications for DBS in Parkinson's disease. Number one is the certainty of the diagnosis. The reason for this is that DBS is not beneficial for other Parkinsonian syndromes. And idiopathic Parkinson's disease is a clinical diagnosis. And so we have to be very careful about referring people too early because we don't want to do an unnecessary surgery. Now, ways that we'll figure that out is by assessment in the office by someone like myself or Dr. Solis-Cohen, looking for characteristic findings of Parkinson's. So that includes Parkinsonism, which is kind of the motor features of Parkinson's, the resting tremor, the rigidity, the bradykinesia, whether the symptoms were asymmetric in onset, and if there's a good response to levodopa. Now, if there are some features that might suggest that maybe we should consider a different diagnosis might be a lot of falls in the first 3 years after diagnosis, or a lot of freezing of gait during the first 3 years, or a lot of hallucinations in that same time period. Or if there was dementia before the motor symptom onset, or within a year of the motor symptom onset, if they have some significant eye movement problems or autonomic findings, meaning maybe their blood pressure drops and they pass out if they stand up, or they have significant urinary incontinence, that sort of thing. Or if they have a history of something else that can cause Parkinsonism, such as certain medications or strokes, or if there's other abnormalities seen on the neurologic exam that maybe we wouldn't expect to see in Parkinson's disease. And so ultimately, the FDA approved DBS for Parkinson's patients that have been diagnosed for at least 4 years. And so that's really what we aim for, is if you've had the diagnosis for at least 4 years, that gives us a little bit more confidence that, okay, we are treating the same thing. You know, we expected at that within the 4 years that maybe some of the atypical features of these atypical Parkinsonisms would have cropped up by now. And so now it might be appropriate to proceed with DBS. And the next thing we have to consider when we're thinking about indications is the degree of disability from motor symptoms. So the idea is we want to do the surgery just as the patient is experiencing enough Parkinson's symptoms that it's actually interfering with their daily function, occupational activities, important leisure pursuits, or other basic activities, essentially. That's kind of the ideal. Now, symptoms like tremor, bradykinesia, rigidity, dyskinesia, motor fluctuations tend to improve with DBS. And so identifying these symptoms as maybe problematic for you as an individual is important, because they would respond to DBS. Motor fluctuations include things like wearing off, early or delayed or no on period after taking the carbidopa levodopa, or maybe those peak dose dyskinesias, or wearing off dyskinesias, or actually getting dystonia. Now, things such as speech dysfunction, swallow dysfunction, small handwriting, severe balance problems, and severe freezing of gait don't respond as well to DBS. And so if your problems are predominantly more on that side, then maybe DBS won't be as beneficial for those things. So the FDA approved DBS for Parkinson's patients that have had recent onset of motor complications, or have had longer standing motor complications that aren't adequately controlled with medications. And then I included this disability from non-motor symptoms here, not necessarily because it's strictly an indication, but it's something good to consider when we're thinking about DBS, because some of the non-motor symptoms do actually improve with DBS. So things that maybe non-motor fluctuations that occur when you're wearing off of your medicine. So pain, panic attacks, kind of fidgety type movements, those tend to respond well. And, you know, depending on which target we choose, but we can often decrease the medicines that you're taking after we start the DBS. And if you're having side effects from medications, well, now, since we're decreasing it, maybe you won't have as many side effects. So another thing we have to consider when we're talking about DBS and considering that is response to levodopa. And so a clear response to levodopa is a good predictor of favorable outcomes from surgical therapy. And the corollary to that is that it's unlikely outcomes will ever be better than the best pre-operative levodopa response, except for tremor. Tremor does tend to respond very, very, very robustly to DBS. So the way we assess this is with on-off testing. So this entails doing a detailed examination, first in the most symptomatic state or the off period. And so we typically do that by maybe having you come in first thing in the morning to our office and having not taken your medications that day. After we do the exam, we have you take your regular medications and then wait for them to take effect, however long that takes. And then we repeat the exact same exam in the least symptomatic or on medication state. And when we're doing these exams, we can actually tally up, the severity of the symptoms. And what we're looking for is a minimal degree of improvement of 30% between the off and the on state. If you improve by at least 30%, that indicates that you're going to respond favorably to the DBS. Now, we also have to consider cognitive and behavioral status when we're talking about DBS indications. So all of the patients that we refer for DBS first have to get neuropsychological evaluation. This is a test done with a neuropsychologist over several hours that are assessing several different domains of cognition, whether that's language, memory, executive functioning, and also looks at mood. And so if there's uncontrolled mood issues, such as uncontrolled depression, we need to address that before we go to surgery. And at the same time, if we detect any dementia on the neuropsychological testing, that is a contraindication to surgery. Now, if you have mild cognitive problems, that is not necessarily a contraindication to surgery. Now, the thought process behind the dementia contraindication is actually somewhat interesting. Initially, this was put into place as a contraindication because it was recognized that the ablative or lesioning surgeries that I was talking about at first, the pallidotomies, the thalamotomies, can cause behavioral cognitive changes, particularly earlier on when they were newer. And specifically DBS of the subthalamic nucleus has been noted to cause some verbal fluency issues. Now, that being said, there was a recent study in 2020 that indicated that DBS does not increase the risk of dementia. But there is also still the practical consideration that a dementia patient can't reliably participate during the programming sessions, in which we really rely on communication from the patient and cooperation to do certain exam maneuvers. And if we can't do those things, it really limits the utility of the DBS. And then, of course, we also have to consider other medical problems before referring to surgery. And so if you have say a severe heart condition that would not let you have surgery, then unfortunately we wouldn't be able to do DBS in that case as well. And that slide also, I should say, the part about behavioral cognitive status, other medical complications, that is not only in Parkinson's disease. This also applies to essential tremor patients as well. So moving on specifically to essential tremor. So again, we want to be sure of the diagnosis. The reason for this is that Parkinsonian tremor, essential tremor, and other tremor syndromes such as dystonic tremor are utilize different targets in the brain when we're doing deep brain stimulation. And 30 to 50% of patients with essential tremor are misdiagnosed with Parkinson's or some other tremor syndrome. And while DBS has been applied in other tremor syndromes, not necessarily essential tremor or Parkinson's or dystonic tremor, the post-operative course is much more variable and harder to predict compared to just essential tremor, where most of the data and studies have been done on.
Dr. Zaza, we're running about 5 minutes over at this point. So if we could let people know that we're going to wrap this up and then move on to question and answers, that'd be great. Thanks.
Perfect. Yeah. Yeah, and I have only just one or two slides. So we also need to think about disability. So if your tremor is impairing eating, dressing, or is just socially embarrassing for you, and the medications aren't cutting it as far as controlling the tremor, then that is a good reason to have DBS. And that's actually the end of my slides there. So we can, I guess, move on to the question and answer session then.
Okay, so I guess we can go through the questions and I'll sort of pass them along as I see appropriate. How about that? And I just have the window. Here we go. All right. So the first question is for Dr. VanSickle. It is about a pacemaker, defibrillator, and will a person be eligible for DBS of essential tremor because of that factor?
The answer is yes. So being able to do the sleep technique depends very much on being able to get an MRI. Sometimes the pacemaker or defibrillator is not MRI compatible, but even oftentimes when they are stated to be not MRI compatible, an MRI can still be performed under certain protocols, and we have those here at Littleton Hospital. So in almost all cases, the answer is yes.
Great. Let's go to a question for Dr. Zaza. Explain, please, if DBS can have a side effect on a person's personality, mood, behavior, or cognition. And I would personally add that that is a difficult question to ask straight away, but I'm sticking it to you, Dr. Zaza.
Yes, that is true. So as I kind of mentioned at the end there, it's kind of an active area of research. And so please explain when if DBS has a side effect. So in 2020, there was a study done on STN DBS patients, a large series of them, that showed that they did not have an increased risk of dementia. Now, there has been some changes associated with verbal fluency with STN DBS, kind of word hesitancy, and then other DBS procedures can cause other issues with speech, such as some of the thalamotomy procedures can. But as far as mood, that's a little bit harder to answer. I'm not sure of any direct studies showing a direct effect on mood when we're doing DBS for essential tremor and for Parkinson's, but there has been applications of DBS in psychiatry. And so that would be kind of something that we would have to assess every time when we see you in the office. And then if there were some concern for that, we might want to verify the placement of the leads. And I guess I should say, actually, in STN DBS, that can cause, if a certain part of the STN is stimulated, it can cause changes in mood in some patients, which we would hopefully be able to get around with the directional stimulation that Dr. VanSickle was talking about.
Yeah, I agree with you, Dr. Zaza. I've seen a couple of cases where it's really important to know what a person's mental state is like before surgery, and knowing folks really well helps optimize outcomes with stimulation, because once in a while, if we're stimulating in an area of the brain that's sort of a little off our desired target, we may see some fluctuations in mood, but it's rare, just like you mentioned. So, all right, I'm gonna give Dr. VanSickle a couple questions that you can fire away with. One is this covered by Medicaid, Medicare? And then the second one is, do you know about new generations of rechargeable generators coming out? And then actually I'm gonna give you three. The third one is failure rate.
So you're testing my memory.
Yeah, this is short-term memory.
So Medicare and Medicaid, yes, this is covered by Medicare and Medicaid. We can do surgery with either of those. Failure rate, maybe I answer that a little more broadly with complication rates in general. And that's something that we have failed to talk about, but is really quite important. Complications can be divided into two groups. There's things that I can fix and things that I can't fix. The big thing that I cannot fix that we all worry about the most, and that is a DBS during the process of surgery can give you something like having a stroke where you have bleeding inside the brain. It is fortunately very, very rare, but when it happens, it can leave somebody with a permanent neurologic deficit. And so that's something to know about before making the decision. Then there's everything else, which can be fixed. So if you look at the statistics, there is less than a 1% chance you could get an infection. If it happens, though, we have to take the whole system out, give you antibiotics, put it back in. That used to be years ago as high as 10%, and then it's dropped to about 3.5%, and in our practice is under 1%. A lead can be misplaced. No matter how good a technique is, there's always a chance a lead's not placed exactly where we want it to be or where it's going to do the most good. And about once every other year, I will move a lead to a different location or make a slight adjustment to it. A lead can break. I've seen that happen before, especially with the extension lead, and that's the connection lead that goes behind the ear down to the chest. And I seem to replace one of those about every year. So if you're doing, 70, 80 of these a year, you can do the math and say it's a little over 1% maybe that has that issue. And if you add all the complication rates up, we're running in and around 2%. So about 2% chance that something will happen where we have to do a surgical adjustment of some kind, and about 0.1%, 0.1%, or one chance in 1,000 that it could be really problematic and we wouldn't be able to fix it. So I think that's answering that question. And what was that third question again, Luisa?
The third question is new generations of rechargeable batteries.
New generation rechargeable. So there are rechargeables that exist now, just not from Abbott. Abbott, I think, makes the best technology, and that's the one that I prefer to use. But Boston Scientific makes a good quality rechargeable battery right now that you can have, as MRI compatible, just like the Abbott device. It does not have remote programming. And Medtronic makes rechargeable, though I wouldn't recommend that one at the present time. I do know that Abbott is working on one. I've heard it's going to be available early next year, but they have not released a date. So I can't comment on when it's actually going to, I can say I've heard about it coming. I can also say that most individuals
are... nudge. I'm sorry, Dr. VanSickle, I'm getting a little nudge that we sort of need to get into these questions that apparently they're numerous. I'm going to unfortunately skip some of the individual questions that are related to individual anecdotes related to their surgery and whether leads need to be revised, because that's a highly individualized approach. And I think the audience may not benefit from that sort of discussion point given the time crunch. There is one question about if you're out of state, what is your first step to determine if you're a candidate? It may be worth looking into that locally and going through that candidacy consideration locally to sort of optimize time, but you are welcome to come see Dr. VanSickle, myself, or Dr. Zaza for an independent assessment, of course. So a person has had good success with Medtronic leads from an awake surgery before. Should they consider getting new directional leads as a person gets older? I would say straight away, if you're having great success, the answer is no. That means your leads are generally well placed by your surgeon and you should stick with them. The risk of another surgical intervention is probably not worth it. Another one is, how long do the batteries typically last? Potential contraindications for patients with Parkinson's. Wow, length of recovery time, percent of implants that are malfunctioning. So let me put it this way. Dr. VanSickle, why don't you get the how long do the batteries typically last and the length of recovery time from surgeries? And then maybe Dr. Zaza, you can talk about some contraindications that you may think we missed to readdress.
So with the Abbott system and 2 small generators, you should get 7+ years on average. That doesn't mean that you'll get that. Some people get less, some people get more, depending on their settings. And what was the other one there, Dr. Solis-Cohen?
How long do they last and length of recovery time with the
length of recovery. It's not a very painful surgery. So from a physical perspective, the recovery should be very short, literally just a few days. However, many people will have a slight cognitive deficit that is transient. As Dr. Zaza mentioned, long-term cognitive deficits really are not apparent in most individuals, but a 2 or 3 week period of time where maybe you're not quite yourself, that would be fairly typical, and you should expect that and prepare for that in and around surgery.
And then as far as potential contraindications for patients with Parkinson's, and so, I mean, number one is if you have had diagnosis of Parkinson's, not necessarily the symptoms, but the diagnosis for under 4 years. Number two would be dementia or uncontrolled mood issues. And so we'd want to get maybe something like an uncontrolled depression under control before proceeding. If the Parkinson's is not basically idiopathic Parkinson's disease, so if we could say that it's MSA, PSP, et cetera, or due to strokes or due to medications, that would not be a good reason to get DBS. I think I covered all of them, unless I'm forgetting one.
Oh, I think you're good. I'm going to answer one myself, and that is a good question from a person who's asking about essential tremors, whether they need to wait the 4 years post-diagnosis to be a candidate. And the answer is no on that. If you have medication refractory essential tremor, which means you have tremors that are not responding to medications and are interfering with quality of life, you don't have to wait a 4-year marker for that. The next question is for Dr. VanSickle. Some of the literature suggests that a pallidotomy is as effective as DBS, but less invasive, less expensive, and less maintenance heavy. Do you agree?
No. Well, maybe in part. It is generally not as effective as DBS, and the literature would heavily suggest that. It is more invasive. You're actually destroying part of the brain, where DBS really does not cause nearly such an injury. It burns bridges where you cannot go back and make corrections, unlike a DBS, which could be removed if you didn't like it. A pallidotomy is going to be permanent. You're going to have it forever. It has more side effects. So any side effect that occurs from DBS, you can potentially program around, or, in the worst case scenario, move an electrode. Whereas if you do a pallidotomy and destroy an area of the brain, you're stuck with it. So if they destroy, possibly an area that's adjacent, and you have some speech effects or some balance effects, you're stuck with them lifelong. So I think pallidotomy should be relegated to sort of the history of neurosurgery and not pursued from this point on. And that's true with most programs around the country. It may be less expensive. That actually may be true, but most of us would not recommend moving forward with it at all.
Yeah, we're all shaking our heads vigorously here, so we agree. I'm going to give Dr. Zaza a question. Got a question: as levodopa decreases in effectiveness, will DBS at some point not be as effective over time?
That is an interesting question. The short answer is no. So the effectiveness of the levodopa or the ineffectiveness of the levodopa does not necessarily correlate with the DBS becoming less effective over time. Now, there was some early thought that there is a phenomenon called habituation in DBS, in which it's possible that the brain becomes accustomed to the electrical stimulation and because of that, the symptoms are not as well controlled. More recently, the data for that has shown that maybe is not the case, but as far as I'm aware, the data has not been conclusive that no, there is no such thing as habituation, or that it does occur. But it doesn't necessarily have to do with how you respond over time to the levodopa itself.
Great. There is a question that I'm going to answer. Okay, if the procedure has been done and future improvements become available, can we take advantage of those improvements? And that's an individualistic question with an individualistic answer. It depends on if the technology you have has an upgradable feature or not. So that would sort of be a discuss it with your doctor because we may have a different answer depending on the technology that you have. I would also mention it's important to consider the technological differences of the three systems before committing, and may want to sort of educate yourself about that. Dr. VanSickle, you're getting quoted here, so listen carefully.
Okay.
Dr. VanSickle mentioned that there were unacceptably poor outcomes with the previous standard awake procedures. Have there been any unacceptably poor outcomes with the asleep procedures?
Absolutely. There is no procedure that is perfect 100% of the time. So the complications we talked about previously, such as stroke with bleeding inside the brain, or with electrodes that break or need to be moved, I would consider those unacceptably poor. Also, there are some individuals that respond differently, and it may be that we were wrong about their disease initially, that they didn't have the typical Parkinson's like other people have. And that may account for some individuals that don't respond the way we expect them to respond. However, the number of such individuals is vastly smaller than it used to be. And that has to do with the fact of putting leads in a much more accurate location or precise location than we were able to in the past.
Great. There's a general question about any new batteries coming out, smaller, longer lasting, when? Either of you guys can take that.
It's hard to comment on technology which has not yet been announced by the companies. So sometimes we hear about things and it could be, they could never come out with it. It could be next year, it could be in 5 years. And it's so hard to know for us.
Does the procedure for essential tremors, let me put this one to Dr. Zaza, okay? Does the procedure for essential tremors help with unsteadiness as well as essential tremor?
No, unfortunately not. It especially in essential tremor, the benefit is strictly in the tremor. It does not help the ataxia that you can see with essential tremor.
And then for Dr. VanSickle, when you have an insulin pump and a glucose sensor transmitter, can you proceed with DBS?
Yes, it should not be a problem at all. We would want to make sure your glucose was well controlled and your hemoglobin A1C was well normalized, could reduce your risk for infection with surgery, but we should be able to work around that with no problem.
Okay, so I'm going to answer this one. A person missed the answer if Medicare covers it. Yes, the answer is yes, they do. When you say 4 years, do you mean from the DAT test or from tremors in the hand? We mean from the onset of symptoms. We argue of whether or not that should be onset of symptoms versus year of diagnosis, but that's generally speaking from onset of symptoms. It doesn't time from a DAT scan. In fact, a DAT scan is not necessary because it's a clinical diagnosis, like Dr. Zaza has mentioned. We're talking about Parkinson's. Let's see, I'm going backwards. Somebody is referring to Moore's law of innovation. And I guess Dr. Zaza and Dr. VanSickle should answer this one. What are your thoughts about less invasive upcoming procedures, or maybe they're referring to high frequency ultrasound as an alternative approach? Either of you have opinions on that?
I mean,
Yeah, I can probably go ahead, Dr. Zaza.
I was just going to say that, I mean, as far as Moore's law, I mean, the main way that is, I guess, manifested in DBS is the miniaturization of the pulse generator. And so every time that one of the companies, be it Abbott, Medtronic, or Boston, come out with a new battery, they tend to be smaller but more efficient. And so, that allows, well, it's more of a cosmetic advantage because it doesn't stick out as much under your skin, but it's still significant. But that is true. There are other procedures, surgical procedures for Parkinson's and essential tremor, such as focused ultrasound, which kind of is a riff on the old ablative procedures. And maybe I'll let Dr. VanSickle kind of take it from there if he has an opinion on the focused ultrasound or other things.
Yeah, I've looked at the data for focused ultrasound in depth, and there may be individuals where that is the best option. We've chosen not to offer it in our program. Overall, the reason why is that It is actually only for essential tremor. It's not FDA approved as of I know right now for Parkinson's, and only for one side. So you can't treat tremor in both hands. You can only treat tremor in one. The reason for that, it is a destructive lesion surgery. So it is non-invasive, but you are destroying tissue in the brain. DBS does not do that. And if you destroy areas that are adjacent to where you intended, causing damage to, say, speech areas, et cetera, you can't go back. So there's no way to fix those things. And the tremor control about 1 year later after the procedure is only about 50%. So with all those limitations, it just doesn't stack up well with DBS. That doesn't mean that somebody might not find it better, but in general, it doesn't stack up well with from a data perspective versus DBS.
All right, we're really heading toward the end here. Let's see, Dr. VanSickle, have you trained other surgeons outside the Denver area for folks who can't come to Denver?
Many. I've had, before COVID, we used to have somebody in the OR learning from us, literally every few weeks. That's really slowed down after COVID, and almost gone away. All of them, so there are sleep surgeons that have similar techniques. Maybe it's not robotic, but they're actually very similar in character in several other areas. Much more so here in the West, say in Phoenix or in Oregon, or in Seattle, San Francisco area, much less so in the East Coast. So as you go east of here, sleep DBS gets more rare.
All right, we've got one more question. And that is for you, Dr. Zaza. Can you give us the highlights of the distinction between essential tremor and Parkinson's disease?
So if you look in the book, the distinction is rather stark. Parkinson's, you have resting tremor. Essential tremor, you have an action tremor. In reality, most people don't read the book, and there can be a little bit of a overlap between the two, which can be a little bit, make it challenging to make the diagnosis. But that still holds true for the most part. If you're having predominantly a resting tremor with a little bit of an action tremor, that's going to be more likely Parkinson's, or vice versa, more likely essential tremor. Now, if you're also having features that you would only see in Parkinson's, such as rigidity or bradykinesia, or we could, do other or use other symptoms as hints, such as like small handwriting, things of that sort. That would also be a way to differentiate the two. But so in some patients, it can be a little bit of a challenge, and we kind of just have to see how things change over time.
Great. Well, thank you both for your time. And I think we got some good information really to everybody here. If there are any additional questions, please submit them to info@neurosurgery1.com. And there apparently are numbers and contacts on the slide here. Yep, there are. So again, info@neurosurgery1.com. All right, I'm going to put that, I'll have somebody put that in the chat, I think. Thanks so much. Have a great day.
Thank you, everybody.
Thank you.